Good morning, good afternoon, good evening, wherever you are in the world. It's a great honor for me to welcome you to this special event. I'm Marlies Ostermann. I'm the current chair of the Research Committee of the ESICM. And I'm very honored to spend 30 minutes with Professor Paul Young from New Zealand. Professor Young will be very well known to most of the audience, as he's conducted major clinical trials in critical care that have impacted our clinical practice. For those of you who are less familiar with him, he's the current Deputy Director of the Medical Research Institute in Wellington, New Zealand, and a very senior critical care clinician, again, in Wellington, New Zealand. And as most of you know, he's led and developed many clinical trials exploring very common things in critical care, like oxygen, blood transfusion, stress ulcer prophylaxis, and infection management. So it's a great honor, and I'm very grateful to Paul for making time late in his day. I think it's quite late for you. Is that right, Paul?
It is a little bit late. It's just coming up towards bedtime now. But it's a great pleasure to be here, and the honour's really all mine, because this has been a fantastic collection of talks with some great minds in critical care. And it's a real honour and a pleasure to be here.
Paul, I will wait for questions from the audience. They have an opportunity to put questions in the chat, in the ESICM TV chat. But before they arrive, I'd just like to ask you a question. So you are a very successful, internationally renowned researcher. How did you get there from being a trainee in critical care to now a famous critical care researcher who has impact on what we do every day?
You know, it's a really funny question, because if I try and think about how I ended up in the position that I have ended up in, I don't think that I could do it again if I tried. You know, I mean, I finished my training in intensive care medicine in 2010, and at that point I hadn't published a single paper in a peer-reviewed journal in intensive care medicine, and I sort of wanted to be a clinical researcher, and I was fortunate to be working in an intensive care unit where I was allowed essentially to, you know, do what I wanted to do with my clinical time and find my own path. And so I sort of took the approach of really just pretending to know what I was doing until such point as I actually figured out what I was doing. And so my first clinical trial was a relatively small single-centre study looking at remote ischemic preconditioning in high-risk cardiac surgery, where I sort of consented all the patients myself, and I wrote the protocol myself, and I wrote the case report form myself, and I enrolled all the patients, I collected all the data, and I managed to get that trial done, and it was incredibly difficult. And it took quite a bit of time, and it wasn't very good. But I sort of recognised quite early on that if I was going to be successful in research, that it would be really important to align myself with people who were successful and people who were able to get funding from peak funding bodies. And so I basically looked at who in my hospital had got money from the Health Research Council of New Zealand, which is the peak funding body in New Zealand that funds investigator-initiated research. And there was one person in my hospital who had got funding, and in fact, they got funding to conduct a randomized placebo-controlled trial of paracetamol in patients with influenza. And so I thought, well, I mean, we could do a study looking at paracetamol in patients who've got fever and infection in the intensive care unit. I mean, that seems like an important question. We give a lot of paracetamol out. And so I wrote a grant and someone else agreed to have their name on it because I had no track record whatsoever. And that person, who was Richard Beasley, who's the director of the Medical Research Institute of New Zealand, supported me in the process of writing that grant, and the study got funded. And so then my second randomized controlled trial got published in the New England Journal of Medicine. That was the HEAT trial. And that was really where it started. And from there, I formed closer bonds with senior members of the Australian-New Zealand Intensive Care Society Clinical Trials Group, including people like Ronaldo Bellomo and Simon Fintfer and John Myberg and Jamie Cooper and Sandy Peake and many other people who've always been great collaborators. And so things have really just evolved naturally from there. And I feel like, you know, the other thing that I've always tried to do is I've always tried to be a valuable collaborator. So I never want to be a passenger on anything. So if I receive, you know, a paper to provide feedback on, then I'll genuinely engage with it and I'll do my best to add value to it and to try and make it better. And the same with every study. You know, I do my best when I'm participating in my hospital and other people's trials to enroll as many patients as possible. And I guess to be a collaborator that other people feel makes a worthwhile contribution. So that's my rather prolonged answer to your opening question.
Thank you, Paul. That's it's very interesting to hear that you said you had never done a clinical trial until you started working, and now you've got many trials under your belt, and you've got, I think it's 10 New England Journal of Medicine papers in your name. So
as of just recently. Yep, that's right.
It's very impressive, and it's encouraging for all of us, and in particular for trainees. Can I get back to, you've already mentioned the HEAT trial, but I'd like to go back to the PLUS trial, which has just been published. And it also has already generated some questions on the chat. So in the PLUS trial, you compared buffered solutions with saline, tried to answer an important question which has exercised a lot of us. And you showed no difference in mortality despite enrolling more than 55,000 patients. And you showed no difference in severe acute kidney injury. So the question from the chat is, what do you do in your own clinical practice now?
Well, I mean, I think one important point to make is that I think you need to view the PLUS trial not in isolation, but in the context of all of the other trials that are being conducted. So there've been a number of really high quality trials evaluating balanced crystalloids and saline in patients who are critically ill in the intensive care unit. And the PLUS trial really is, I think, in many respects, the final piece of the puzzle in terms of large-scale clinical trials in this space. If you look at every one of those trials, the point estimate with respect to mortality favours balanced crystalloids. And if you add up all the deaths in the balanced crystalloid group in all of the large, high-quality randomised controlled trials in this patient population that are with a low risk of bias, you end up with a 0.8% absolute difference in mortality between the two groups based on the point estimate. And, you know, in the meta-analysis that was published in the New England Journal of Medicine at the same time as the PLUS trial, the 95% confidence intervals to go with that absolute difference of 0.8% by point estimate range from, you know, a modest reduction in mortality with balanced crystalloids up to sort of just crossing the line of no effect with a p-value of 0.07. And in a Bayesian analysis that accompanied that frequentist analysis, there was an 89.5% chance that balanced crystalloids reduce mortality on average compared to saline when they're used for ICU fluid therapy. So my take on the current state of the evidence is that given that these are widely available fluids that are, you can choose between them, you know, without difficulty, and they're not expensive, I can't understand how anyone would look at data from a series of comparative effectiveness trials that show an almost 90% chance that on average choosing balanced crystalloids is better, how people would do anything other than choosing balanced crystalloids in general terms. Now, you know, there are some exceptions, and there was and there is evidence of heterogeneity of treatment effect, with the pretty strong suggestion that for patients who have traumatic brain injuries, saline actually reduces the risk of mortality compared to balanced crystalloids. And there is, I think, ongoing uncertainty about whether that risk with balanced crystalloids also extends to patients who are at risk of cerebral edema who have other acute brain pathologies, including things like patients who have hypoxic ischemic encephalopathy and patients who have subarachnoid hemorrhage and stroke. But my take on where we're at with the balanced crystalloid story is that for most situations, the best choice based on the data that we have available to us is balanced crystalloids, and a 0.8% absolute mortality difference corresponds to a number needed to treat to save one life of 125. And so when you consider that millions of litres of crystalloid fluid therapy are given to patients all around the world in intensive care units, you know, every day, that's actually an effect on mortality that's profoundly important for global public health.
Thank you. There's a question from the chat. Do you think this is the end of any further fluid trials? Have we answered the question?
I can't see large-scale fluid trials in heterogeneous critical care populations in the foreseeable future, because I think, you know, for the balanced crystalloids versus saline story, given that it's comparative effectiveness of treatments that are widely used and widely available, an almost 90% probability that one option is better than the other, I mean, that should be enough. And it's hard to see how you would justify doing another large-scale trial to make that comparison. Now, you know, whether other fluid questions emerge and whether there's need to answer specific questions in certain populations of patients or in different settings other than the intensive care unit setting, well, I mean, that's possible, but I personally can't see another large-scale trial in a heterogeneous critical care population happening in the foreseeable future.
That's clear. So, Paul, most of your trials focus on practice, routine clinical practice, things we do regularly at the bedside. And you've done trials related to infection. You've already mentioned your heat trial. There's a question in the chat, and the question is procalcitonin still a useful tool to use antibiotics? So do you use procalcitonin in your routine clinical practice as a guide?
So it's not even a test that's available in my hospital. So I can honestly say that in my entire intensive care career, I've never ordered a single procalcitonin.
Would you like to have procalcitonin if you had the opportunity?
I would have to say that I'm not really familiar enough with the literature in the area to give you an informed comment about that. Yeah, I can't answer the question. I don't have the expertise.
I have another question here from the audience, and this question relates to this sometimes seen as a bit of a challenge between pragmatic trials and individualized therapy. So on the one hand, we all aim to personalize our therapy to give individualized management, but we rely on trials like PLUS or use your stress ulcer prophylaxis trials where thousands of people were randomized to one or the other therapy. How do you bridge this dilemma?
Yeah, I mean, look, it's a really important question there, and I think, in a sense, I don't think the dichotomy is all that helpful, right? So I guess the problem I have with saying, oh, we don't need any pragmatic trials and the only thing that you should do is just individualize the therapy, is that the only sense in which the therapy then becomes individualized is to the doctor and whatever internal narrative they've created in their head. And I just struggle with the notion of how really individualizing that therapy in that way, particularly when it's individualized around physiological surrogates, can be useful. Because actually we know from a range of different clinical situations that making the physiology better can make the patient in front of you look like they're better, but make them more likely to die. But that is not to say that I believe that we should just treat every patient the same. In fact, I think that where we actually need to get to is a position of being able to explore heterogeneity of treatment effect in a meaningful way using trials that have randomized enough people to be able to meaningfully understand what happens, not just on average, but what happens to specific subsets of patients. And so in relation to the fluid therapy space, and in particular the comparison of balanced crystalloids and saline, we have a really great collaboration of investigators who've conducted the large-scale randomized controlled trials where we now have data from over 35,000 patients who've been randomized to saline or plasmolite or balanced crystalloids. And we're in a position to conduct individual level patient data meta-analysis to understand whether there are particular subgroups of patients where one therapy or the other is better. So a lot has been said about the notion that all you need to do to decide which fluid to give is look at the chloride, right? So in the individual patient data meta-analysis, we'll be able to look at the patients who have a low chloride, a normal chloride, and a high chloride, and we'll be able to establish whether or not actually the chloride level is a determinant of the response to therapy or not. Because it might be, but it also might not be. The same goes for things like the degree of acidosis. And also, I think, for the conditions that we've already talked about, where the patients may be at risk of cerebral edema, understanding whether saline is actually the best choice is only going to come from randomized data where we're in a position to draw strong causal inferences about the effect of therapies on outcomes. I think another example of the way in which you can potentially get to this question of individualizing treatment and being confident that in individualizing the treatment that you're choosing the right treatment that doesn't just improve a physiological surrogate, but actually results in a patient having a better outcome, is the MEGAROX trial. So in the MEGAROX trial, we're enrolling 40,000 patients who require unplanned invasive mechanical ventilation in the intensive care unit. And within that trial, within that overarching 40,000 patient trial, we have a series of parallel nested trials in important subgroups, including patients with sepsis, where we hypothesize that liberal oxygen therapy is better, patients with hypoxic ischemic encephalopathy, where we hypothesize that conservative oxygen therapy is better, and patients with acute brain injuries, other than hypoxic ischemic encephalopathy, where we again hypothesize that more liberal use of oxygen is better. And so within the MEGAROX trial, and also within its individual nested trials, we have very large numbers of patients, and we're adequately powered to detect, I think, what everyone would regard as realistic treatment effects that might be attributable to the oxygen therapy regimens that we're testing. And so I guess my answer to the should the treatment be individualized or should we just give the same thing to everyone, or should we individualize treatments or do pragmatic trials? My answer is that we should do large-scale pragmatic trials so that we can individualize treatment based on the effect that treatments have on patient-important outcomes, not based on the effect that they have on physiological surrogate measures that might be misleading.
Gosh, sounds fantastic and very novel and clearly in line with your overall approach to research, i.e. finding new research methodologies. And that brings me to a question which is again from the audience, and it really relates to us and our responsibility towards trainees. And the question is, how do we develop the next generation of researchers? What is our role and responsibility?
That's a really great question. And, I think it's one that is really hard to answer because I think that the honest truth of it is I don't really think that research is for everybody, right? So I think there are some people who are, really drawn to it, who are going to end up doing it no matter what. There are some people who will never do it no matter what. And there's some people in the middle who, might well be swayed by their experiences. I think that for me, I was probably going to do it no matter what. But my initial experience of trying to do it by myself wasn't very much fun and didn't lead me to doing research that was meaningful. And so I do think that it's really important that when people show an interest, that when you're in a position like I'm in, that you try and do your very best to support them. But at the same time, I think until you've done research, it's really hard to know if it's really for you. And in particular, I think actually a huge portion of being a successful researcher is writing. So if you don't really genuinely enjoy writing, then you'll find it really hard to actually do clinical research and to be effective. On the other hand, if you can't help but do writing and you're drawn to it, then I think that you will be in a much stronger position to actually be able to make a career of it.
That brings me to my final question in the last 1.5 minutes. And the question is, what should trainees do who would, if they are interested in a career in critical care research and ideally would like to run trials and have New England Journal of Medicine papers? What is your advice to the next generation of trainees?
Well, I mean, I do think there is a lot to be said for pretending to be it until you become it. So, I guess what I mean by that is if you want to do clinical research, you should do it. Once you start doing it, then you're a researcher. And in the initial stages, that does mean doing a lot of stuff for yourself, but everything that you do, you learn and you get a bit better. The other thing that I think is really important is to align yourself with people who have had the kind of success that you would like to have. So if your aspiration is to conduct clinical trials that get published in the New England Journal of Medicine, find someone who has done that and attach yourself to them so that you can learn from them. Now, everyone who's published a trial in the New England Journal of Medicine, right, they're not all going to be helpful for you, but there's a lot of people, I think, who are out there who are successful researchers who, thrive on the opportunity to support new and upcoming people. So I think the best strategy is to make yourself known. And if you find someone, you don't make a connection with them, and you still want to do it, then find someone else. Find someone who fits.
Thank you, Paul. I'm afraid we've come to the end of this session. I could go on forever. There are a few more questions, but I'm afraid I have to stop. I'm very grateful for the opportunity, and I'm sure the audience is very grateful for your listening to you and for your very practical advice. And good luck with the next trial.
Thank you very much, and thanks very much for your time.